Okay, here we are. This is going to be the bleeding in pregnancy lecture. Now, there is only one PowerPoint for this lecture. The PowerPoint includes early bleeding and late bleeding, but I am going to divide this into two separate lectures because it's a lot of information. So during this recording, I am going to talk about bleeding early in pregnancy, and then the next recording, which will be for next week, is going to focus on late bleeding in pregnancy. Oops. Okay, so the first condition that we're going to talk about is called a hydatiform mole. You may hear it referred to more commonly as a molar pregnancy. What this is, it is something went wrong during fertilization, and there isn't an actual fertilization of the egg by the sperm. So there is not an actual fetus present during a hydatiform molar pregnancy. I can't explain to you why it is still called a pregnancy, maybe only because it began like a pregnancy with an egg and a sperm fertilizing, and then something went wrong. We don't know what causes molar pregnancies, and it turns into this fast-growing condition of these vesicles, and they refer to them commonly like a cluster of grapes. And you can see down here where it looks like a bunch of bubbles. Well, these are just actual liquid-filled vesicles, and this is what it looks like in reality. Okay, the key here to remember is that fertilization did not happen the way it was supposed to, and there is not a viable fetus. So even though it is called a molar pregnancy, there is not a fetus present. Okay. Okay. Signs and symptoms. This is usually diagnosed probably towards the end of the first trimester. The woman is going to start having bleeding because these vesicles are going to start to rupture as they become too full inside the uterus. So she's going to start to have bleeding. The bleeding is often described as a dark red to brown bleeding resembling prune juice. If they were to measure the uterus is going to be larger in size than what it should be at that time in the pregnancy because of all of the vesicles. These vesicles grow very quickly, very fast, and so the uterus is often larger than what it would be if it was an actual pregnancy with a fetus. The woman may become anemic because of the bleeding that is caused, and they typically will complain of excessive nausea and vomiting because of increased estrogen levels and the HCG levels that occur with this type of condition. One other key factor that happens with the hydatiform mole is preeclampsia sometimes. We talked about preeclampsia before spring break, and if you remember, I said that preeclampsia occurs in the second half of the pregnancy. This is an exception to that rule. A woman with a hydatiform mole may develop preeclampsia, and this is in the first half of the pregnancy. So if you have a woman who comes in towards the end of her first trimester, beginning of the second trimester, and has a true case of preeclampsia, then it might be a red flag to assess her for a hydatiform mole or a molar pregnancy. How do they diagnose a molar pregnancy? Is by doing an ultrasound. Of course, on the ultrasound, there will be no fetus in the uterus, and it will show this pattern where it's just kind of fuzzy, and they call it a snowstorm looking pattern. But the key is there will be no fetus visible in the uterus. Also, they will draw HCG levels. Remember that the HCG levels are the markers for pregnancy, and this level will be higher than what it should be during a normal pregnancy with a fetus in the uterus because the tissues inside the uterus, that trophoblastic tissue, secretes HCG. So you're going to have higher than normal levels of HCG. The treatment, the management of a hydatiform mole is to remove all of the abnormal tissue. This is done with what's called a D&C, or a dilatation and curettage. This is when they insert an instrument up into the uterus and they scrape out the uterus and suction out all of the tissue in the uterus. And so the goal is to remove all of that trophoblastic tissue. Even though I know there was not a fetus in the uterus, for some reason, they still treat a woman with RhoGAM if she is Rh negative. This is a loss for the woman. She may have known she could possibly be pregnant. She may have just found out about this. So this could be a loss for her, especially if she thought that she was pregnant. So we want to provide emotional support. She will also need emotional support because this is a lengthy follow-up or recovery for 1 whole year. We do not want her to get pregnant during that first year after this molar pregnancy. What can happen is if during the D&C a piece of trophoblastic tissue is left behind, it can then start to grow and proliferate again. And so she will be followed up closely for that first year to make sure that that didn't happen. So she will have frequent visits and they will monitor her HCG levels, because if the tissue starts to grow back and starts to increase in amount, then her HCG levels will increase, and so that's why they monitor that. And we want her to avoid pregnancy because it will just complicate matters just in case all of the tissue wasn't removed. If she's pregnant and that starts to grow back, then it makes management and treatment very difficult, okay? I do want you to know that a woman who is treated for a hydatiform mole effectively and all of the tissue is removed and she makes it to that 1 year marker, many of these women, they go on to have a normal pregnancy and deliver a baby later on. Okay, ectopic pregnancy. Another condition that can cause bleeding in the first trimester of a pregnancy. Okay, so remember during the prenatal, at the beginning of the prenatal visit, we talked about how the egg is released from the ovary into the tube and the sperm comes up, and then the egg and the sperm fertilize somewhere up here in the fallopian tube. And then the fertilized egg travels through the fallopian tube and falls into the uterus and implants, okay, and then establishes as a pregnancy and grows. Well, what happens with an ectopic pregnancy is the egg and the sperm fertilize, but for some reason it does not travel through the tube and fall into the uterus. It may go backwards and fall back out of the tube and actually try to implant in the abdominal cavity or on the ovary. This typically, 99% of the time, this pregnancy cannot establish and continue on. There is just nowhere in the abdominal cavity or on the ovary that the pregnancy can attach, implant, and then grow healthy, okay? What commonly occurs, this is the most common ectopic pregnancy, is that the egg and the sperm fertilize here in the fallopian tube, and it travels a little bit and then it gets stuck and it implants inside the fallopian tube. Okay, now if you remember and think about how big a pregnancy grows, the fallopian tube cannot withstand a pregnancy, okay? And then something is going to happen to that tube. And so ectopic pregnancies, the treatment of ectopic pregnancy causes damage to the fallopian tube and many times leads to infertility because then it makes it more difficult for the egg to and the sperm to get fertilized. Sometimes the tube actually has to be removed, and so they can't even get pregnant on this side. What puts a woman at risk for an ectopic pregnancy is any of these factors that can cause damage to the fallopian tube. It causes scar tissue, can change the anatomy of the fallopian tube somewhat, that causes that fertilized egg to get stuck. Okay? So signs and symptoms. There are 3 classic symptoms and signs of an ectopic pregnancy. Abdominal pain. She's going to start to have abdominal pain on one side of her abdomen because the tube is starting to stretch because that pregnancy is growing. She will have missed her period, her menstrual period, because she is pregnant. Okay? So she may say, oh, I should have had my periods a couple weeks ago or several weeks ago, and I did not. So she may be thinking already that she is pregnant. She may have done a pregnancy test that would show that she is pregnant because there is a pregnancy and she would have HCG. Typically, this is about maybe 8, 9, 10 weeks maybe that this happens. And then as the tube starts to stretch, as the pregnancy grows, there is going to cause damage to the tissue in the tube, and she is going to start to have bleeding, so she may complain of some small spotting or vaginal bleeding. Now, if the ectopic pregnancy is not recognized at this point and treated, then as that pregnancy grows, eventually that fallopian tube is going to rupture because it cannot sustain a growing pregnancy. The key, wait, let me get back to that. Sorry. The key symptom, circle this, highlight this, whatever you want to do. The red flag that the ectopic pregnancy has ruptured is she will complain of referred shoulder pain, okay? Which shoulder, it doesn't matter. What is happening is because the tube ruptured and she is now bleeding into her abdominal cavity, that bleeding is irritating the diaphragmatic nerve, and that is what's causing the shoulder pain, okay? Sorry. She will start to complain of more severe pain on whichever side the ectopic pregnancy is happening. And if she still doesn't recognize these symptoms and doesn't seek treatment, the bleeding will intensify and she will go into shock. So a ruptured ectopic pregnancy does become a medical emergency. So diagnosis. Basically, many times they are diagnosed by their signs and symptoms at first. It is important that we think about other conditions and rule them out that might have the same symptoms. If the ectopic pregnancy is on her right side, that pain could be mistaken for appendicitis. Sometimes it can be mistaken for a urinary tract infection, or that she is maybe having a miscarriage. If she's just complaining of general low abdominal pelvic pain, or an ovarian cyst that is causing some pain. So it's important that the nurses who work in OB in the ER are able to recognize the symptoms of an ectopic pregnancy so that we don't get to the point of the tube rupturing. And then to verify the diagnosis would be to take an HCG or a blood sample for HCG levels, and it would come back at a level appropriate for a pregnant woman because she is pregnant and secreting HCG. At the same time, they would do an ultrasound and would not see a fetus in the uterus because it is in the tube. Okay? Treatment. There are 2 treatment modalities, either medical, pharmacological, or surgical. In the U.S., we tend to surgically treat ectopic pregnancies. Medical management is more common in European countries. They can be treated with a medication called methotrexate that is given as an IM injection. It is one injection initially, and basically what it does is it destroys any rapidly dividing cells, which is what a pregnancy is. So it basically terminates the pregnancy and causes the fertilized egg to kind of basically just destroy itself and get released and passed through with the bleeding, okay? This can only be used if the tube has not ruptured and if the fertilized egg or pregnancy is still very small in size, okay? It does have some side effects, but it appears to be effective. As I said, they use it more in European countries. Some patient education, what I want you to really focus on is that the woman would need to report an increase in abdominal pain, which would mean that the methotrexate is not working and that the pregnancy is continuing to grow and the tube is stretching. And if the woman is Rh negative, this is a pregnancy with a fertilized egg embryo in it, so she would receive RhoGAM. Now, more commonly used in the United States is surgical treatment of an ectopic pregnancy. And so which procedure would be done would depend on whether the tube is ruptured or not and the physician. A salpingostomy is when they are going to, both of these can be done laparoscopically. The salpingostomy is where they go in. The tube has to be intact at this point, so it has not ruptured. They cut open the fallopian tube and they remove the pregnancy. And then they stitch the fallopian tube back closed. A salpinectomy, which is probably more commonly done, is where they remove that section of the fallopian tube, okay? The reason why some physicians will not do the salpingostomy is because by cutting open the tube, stitching the tube back closed, you then are creating a situation where scar tissue can develop, and then she is at a higher risk for an ectopic pregnancy in that fallopian tube later on if she becomes pregnant on that side. If a salpinectomy is done, they actually remove the fallopian tube on that side, so there is no connection now from the ovary on that side to the uterus. So if you remember, women ovulate, they switch sides every month, ovaries. So she would not be able to ever become pregnant when she ovulates from that ovary. Okay, so she would only be able to get pregnant every other month, which is very important to let women know afterwards if they want to try to get pregnant again, because it's going to take longer. Okay, so I said this is a laparoscopic surgical procedure, so just general pre-op, post-op care as you would for any surgical patient. Difference is if she's Rh negative, she should receive RhoGAM afterwards. We want to provide emotional support. This was the loss of a pregnancy, okay? She may have known she was pregnant already. She may have thought she was pregnant already, or she may have just found out that she was pregnant already and that she is going to lose that pregnancy, okay? So there could be a gamut of emotions that they will feel, how they will respond. So it's important to provide that emotional support and provide them resources that they can seek out for grief. We want them to not get pregnant for at least 3 cycles or 3 months afterwards. The tube needs to heal. Whether it's removed, whether it is opened and closed, this is surgery and she needs to recover and heal from this, okay? And as I said before, if they do the salpingostomy, that does put her at risk for an ectopic pregnancy again on that side. Okay, that was an ectopic pregnancy. Other conditions that can cause bleeding in the first trimester, and this is usually, it could be anywhere within the first 20 weeks. So the first half of the pregnancy is, the medical term is called a spontaneous abortion. We commonly refer to it as a miscarriage. This is when the pregnancy ends on its own naturally before 20 weeks gestation of that pregnancy. And a miscarriage or a spontaneous abortion is classified into these different types. Okay? A threatened abortion or miscarriage is just that. The body is thinking about miscarrying. So in order for the pregnancy to actually miscarry, the bag of water has to rupture and the cervix has to open so that the pregnancy, the tissue of that pregnancy is passed, okay? Now, depending on how many weeks she is, that tissue passed is going to look different. If it is early, within the first 12 weeks, it's not going to look like a fetus or a baby. It's going to be bleeding, it's going to be blood and mucus, and they may not even recognize the tissue per se. If it's later, if it's in the second trimester, 13, 14 weeks and on, then it may look like a very tiny infant, okay? Kind of like what you see here, okay? But it would be very small, like it would just fit in the palm of my hand, okay? And so they may recognize that tissue. So that's why the word tissue is used, okay? So back to what I threatened. A threatened spontaneous abortion means that the body is, for some reason, thinking about terminating this pregnancy. And so if you just think about these pictures, then we're going to go here. So I put them into a grid for you to see in one place. So if it's a threatened abortion and the body is just thinking about miscarrying, she will have some mild cramping. She might have some mild bleeding or spotting. When she comes to seek health care for this, if she comes to the emergency room or the clinic and they do an exam, they would do a visual exam, probably with a speculum. The cervix is going to be closed. Because the cervix is closed, she'll tell you that she noticed a little bit of bleeding, but no tissue or mucus like that, okay? An inevitable spontaneous abortion is just that, inevitable. Inevitable means it's going to happen. There is nothing we can do to stop it, unfortunately. So when the woman comes to seek treatment for an inevitable miscarriage, her cramps are going to be more severe. She's going to have more bleeding. The cervix is open, and she will probably say that she passed some kind of tissue, okay? And incomplete means that she's still in the process of miscarrying when she seeks medical help. She will have increased bleeding, increased cramps, the cervix is open. She will say that she probably noticed some type of tissue that she passed, but not all of it because it's incomplete. There's still some in the uterus. An inevitable means maybe not all the tissue was passed either. There may still be some inside the uterus. A complete miscarriage means that by the time she seeks medical care, she has completed this process of miscarrying, okay? So at this point, she may have been here before, but by the time she comes to see us, her cramps are mild, her bleeding is mild, her cervix may have already closed back up, and she's passed all the tissue, okay? Now, a missed miscarriage is when none of this happens, basically. The fetus dies in utero, but the body, for some reason, does not pass it or terminate. So the miscarriage part doesn't happen. And so the deceased fetus is still inside the uterus. So she will not have complained of having any cramps, any bleeding at any time. She would not have noticed any passage of tissue. The cervix is closed. The key that there is a missed miscarriage is that the uterine size stops increasing. So she comes for her next prenatal visit and there's no change in the size of the uterus because the fetus isn't growing, because the fetus died, is dead. Okay, so this is the key symptom for a missed miscarriage. Management of a miscarriage depends on what type it was. If it is a threatened miscarriage, they will observe her to see if it continues and moves into an inevitable. Many times, once she comes in and they get her off her feet and she starts to rest, then sometimes the body just stops. And she may go on and carry that pregnancy to term. There really is no rhyme or reason. We can't explain it, okay? So they'll do an ultrasound to assess the fetus, make sure the fetus still has a heartbeat. They will put her on bed rest for a while, maybe a day or two. We're not talking about extended, not for the remainder of the pregnancy. And then they will monitor the pregnancy for a little while. Maybe do another ultrasound. Once the cramps go away, the bleeding stops, once all the symptoms stop, and they do an ultrasound that shows that the baby is still, or the fetus is still viable and alive and has a heartbeat, then they will decide how often they want to see her in the office. For an inevitable and an incomplete, since the body may not have passed all of the tissues of conception or the tissues of that pregnancy, they would then do a D&C to remove the remaining tissue, because if it doesn't pass and it's not removed, then it puts her at risk for infection and sepsis, okay? If it's a complete, they need to be sure that all of the tissue has been passed. So they would maybe monitor her for a little while. Some doctors will just go ahead and do a D&C also, just to make sure that all of the tissue is removed, okay? If it is a missed miscarriage where the fetus died in utero but the body didn't pass it, then of course they're going to do an ultrasound to verify that the fetus has died, does not have a heartbeat, and then they can do one of two things. They can either give her Cytotec. Remember, Cytotec is a prostaglandin that can soften. They often use it to soften the cervical tissue before induction, but it also can create cramping and contractions of that uterus. So sometimes they may use Cytotec to induce a natural miscarriage, if that makes sense. Many times they will then just do a D&C and insert the instrument, scrape the lining of the uterus to remove all of the tissue of that pregnancy, and then suction it out, okay? And then monitor her to make sure that she was not beginning to develop sepsis because of that dying pregnancy. So the D&C is going to be done, and then she will be discharged. She's not going to be kept in the hospital for this procedure. So before she goes home, they would probably put her on antibiotics prophylactically. Afterwards, she will have some bad cramping, some pelvic pain just from the procedure. They would probably suggest that she take ibuprofen for that. If she was Rh negative, she should receive a dose of Rogaine before she goes home. And then for 2 weeks, basically, nothing goes inside that vagina. Because in order to do the D&C and insert the instrument into the uterus, it will open up the cervix a little bit because it's a long a rod type instrument. And so it does open the cervix a little bit. Or the cervix maybe was already open if she was having an inevitable or an incomplete. And so that opening now allows passage into the uterus, which could create an infection. So nothing in the vagina for 2 weeks. No bathing, no tampons. For the bleeding, she needs to use sanitary pads. No sexual intercourse. Teach her signs and symptoms of infection. If she starts to develop a fever, she will have some bloody discharge for a few days. It should not become foul smelling. And then, of course, we need to provide emotional support. Maybe give her resources, give her numbers for support groups, because once again, this is the loss of a pregnancy. And she may have known she was pregnant already. She may not have known and just found out that she was pregnant and losing that pregnancy. So there's a lot of emotions that can occur. So it's very important to remember not only the physical care, but the emotional care. All right, the last thing we're going to talk about with the early bleeding is what's called an incompetent cervix. Now, if you think about the word incompetent, it means I'm not doing what I'm supposed to. I don't know what I'm supposed to do, and I'm not doing it. So during pregnancy, the cervix is supposed to stay closed and protect that pregnancy. Okay? So what happens with an incompetent cervix is it doesn't do that. And so at some point in the pregnancy, usually about 14 weeks, an incompetent cervix will just start to open. The key is passive and painless dilation. So this means that the cervix opens without contractions. For some reason, and we don't really always know why, it just dilates. And then the pregnancy, she miscarries. If the cervix is open, there's nothing holding that pregnancy inside. So then she miscarries. Okay, and this usually happens about 14 weeks, 15 weeks, when the pregnancy starts to get too heavy. And so when the incompetent cervix opens, she miscarries. Now, the problem with an incompetent cervix is we have no way of predicting who this is going to happen to, who is at risk for this. It is typically diagnosed after the fact and after she has experienced several miscarriages around 14, 15 weeks gestation. You have a woman who maybe has had, if we look at her history and the doctor notices that she's had 3 miscarriages around that time, then they're going to think, oh, I bet you she has an incompetent cervix. So what they're going to do the next time she becomes pregnant is they're going to perform a procedure called a cerclage. A cerclage is basically a stitch or a suture that is sewn around and through the cervix and tied in a knot to keep it closed during the pregnancy. So that way, the cervix can't open. It is literally tied shut. The cerclage should be performed between 11 and 13 weeks. So remember I said that an incompetent cervix miscarriage usually occurs about 14, 15 weeks, maybe 16. So we want to put that stitch in before that time period. Okay. Once they put the stitch in, that will stay in place. And as long as everything then goes okay, there's 2 things that the physician can do. They can decide that at 37 weeks, they're going to go ahead and remove the stitch. Because 37 weeks is pretty close to term, 38. And at this point, if the cervix starts to open, it's okay. She's close to term. Some physicians will wait until she starts labor. And when labor starts, then they will remove the stitch. Okay? It really is just a physician's preference, how they were trained. When a woman goes in for the cerclage, it's an outpatient procedure. Okay? It's just done with a speculum exam. Okay? It's not like an abdominal incision or anything like that. So it can be irritating to the cervix. So she will be on bed rest for a few days after the procedure. She will not be on bed rest for the remainder of the pregnancy. Many women go on to be very active afterwards. Okay, the limited activity is typically just a few days after the procedure, and then during the remainder of the pregnancy would be very individualized to each woman, whether she continues to have some cramping or not. Okay, but typically the bed rest is just a few days. What we do want to make sure that we tell her is because by stitching the cervix, it sometimes can initiate contractions, initiate a miscarriage. It's not 100% fail-proof or without risk. So we want her to know that if at any time she starts to have frequent contractions, if she notices a leakage of fluid, if she starts to feel pressure down there or the urge to push, she needs to come straight to the emergency room, okay? Because then something wrong is happening, okay? The cervix is either trying to open or she's having contractions. Maybe she went into labor. So any of those symptoms, she needs to return to the hospital for treatment, okay? I have seen many women who have a cerclage inserted and then they go on to complete the pregnancy. Sometimes they might deliver prematurely. Sometimes they will go to term. It's too hard to predict because every person's body responds differently. Okay? All right, that is the topics that are included in the bleeding in early pregnancy. So we're going to stop here in the PowerPoint, and then the next recorded lecture will continue on from here to the end of the PowerPoint for bleeding late in pregnancy.